Most of us really don't like change. I think it's also scary, and I think particularly, in a world where many people feel like they don't have a lot of control over other things in their environment. Once you start making changes to their work environment, which is an area where they do feel they have a lot of control, that can be even scarier. One of the things that's really key is to find other early adopters.
It's going to help. It's going to change workflows, and I'm obviously talking about the positive things. It's going to improve efficiency, but you're right, a lot of these questions are fear-based. That comes back to change management and fear of change.
I also think that a lot of pathologists are scared that this is going to replace them. Digital pathology and AI will replace them. I've been around pathology long enough to have seen multiple different innovations that were thought they were going to replace pathologists, and we've not been replaced yet, right? And now it's digital, and it's never going to replace us. It's going to make us much more efficient and accurate.
This episode is one of our special USCAP episodes that were all sponsored by Muse Microscopy. So let's dive into it.
Welcome, my digital pathology trailblazers, another special episode from USCAP. And today my guest is Dr. Sarah Dray. She's a professor and chair of pathology at UCLA. And she's actually the boss of one of our panelists from yesterday, Dr. Rao, who you have seen in other podcasts. Welcome, Dr. Dray, to the show. Let's talk about you first. Sure. Who are you? What's your background? And basically, what is your attitude towards digital pathology? I already know it's a positive one, but let the digital pathology trailblazers know a little bit more about you.
Yeah, well, it's so nice to meet you and to speak to you today on this podcast. So I am a professor of pathology at UCLA. I'm a bone and soft tissue and GI pathologist. And I consider myself an early adopter for technologies in general. So I was one of the first people nationally to introduce digital pathology in the research setting back in 2007 when I was running one of our research core labs at UCLA. So we introduced digital slide scanning and evaluation, using automated instrumentation. It was very early on.
Early adoption, yes.
Yeah, that was when Apereo really brought out their first system, and everybody was wondering what this was going to turn into, and obviously now it's become part of our routine care of patients and our routine pathology practice. So I'm really excited about your system, though, because I think that we will never fully adopt digital pathology until we get rid of slides, and that's exactly what your system is going to be the first step towards.
Yeah, so the Muse technology, the direct to digital, I think it addresses the main pushback, main pain point that problem that people have with digital pathology, because you have the early adopters, you have the enthusiasts, and they will make everything to make it happen, and I belong to that group as well. But you have the normal people who just want to do their job, want to practice pathology, and if it means adding a machine on top of what they are already doing pretty well in an analog way, and then there's this pushback, and Muse technology is taking this away because they image directly to digital, and that's what the panel yesterday was about. When Dr. Rao was one of the panelists. He presented the research that they did in China. Where does his research and what he does with Muse and other things fit into the bigger picture at your institution?
Dr. Rao is our vice chair for clinical innovation, so he's always on the lookout for new technologies that are going to be revolutionizing our field, and obviously Muse is one of these. So I like to give him a lot of freedom to explore these areas of interest.
I think
he's
lucky to have a boss like that.
Well, I don't think he's lucky. He's very productive, and he.
Yes. When I heard how much data they gathered in 3 days, I'm like, okay, yeah, I would my person also go and get so much data.
Yeah, and he has a long history of doing this, at UCLA. So.
Okay.
I think that when people are themselves passionate about projects, sometimes the best thing you can do as a chair is to stay out of their way and let them continue on. And really, that's what's happened here. I mean, Rao has been, as you know, instrumental in identifying the partners in order to provide the tissues that you need in order to do these clinical trials. And it's just really worked out very well.
We had Dr. Zhao on the panel as well, his partner from China.
Yeah.
She had a cool piece of tech because she had glasses that would provide translation from the panel as well.
Oh, really?
Yes, and everybody was excited about the glasses. But such an amazing piece of equipment to exchange information now, right? the language barrier is not a barrier anymore. Okay, we're going to take the analog, hopefully soon, out of the way. Where do you see this technology fitting into the workflows, and how do you see the deployment? Is it going to replace the traditional way? Is it going to complement the traditional way? And obviously, Muse has a very specific use case that they're working right now on. But once we take the leap, once it's ready, where do you see it changing pathology? Changing the way we practice, changing the way we provide care in general for basically everybody, for the pathologists, histotechnologists, and everybody involved in this pathology-driven diagnostic decisions.
The way that I see it is obviously it's going to have to be a stepwise fashion, as with anything. And I think, the frozen section sphere is the first place that makes the most sense to start, probably. But I do eventually see that this technology will replace, traditional histology. I think that rather than, spending all the money that we're currently spending on chemicals, to preserve these tissues and then storing them in paraffin blocks and in slides that we have to then keep on site for years and years, I think that we're going to just have a piece of tissue that we're going to scan. We're going to perhaps freeze those or find some other way to store those.
That was a question that came up with the panel, because obviously there are requirements how long you have to store the tissues, which tissues, depending on what diagnosis it is. So freezing did not come up as an answer, but yeah, totally.
I think that could be, in the same way that we've developed things like RNA later, which preserves tissues for a long time, it may be that we do that. It's possible that we're going to continue to paraffin embed them, but that whole process affects the tissue quite a bit. So I actually wouldn't be surprised if we just go directly from scanning to freezing, and and keeping a certain number of, or maybe certain weight of tissue or a certain size of tissue. By I think CAP standards will have to change for all this, obviously.
Yes.
But then we'll keep those tissues for subsequent testing. But also, as you know, certainly digital and AI is allowing us to identify a lot of features on histology that we, as humans, can't identify. And perhaps in the future obviating the need for a lot of this molecular testing that we do. So it may be that in the future we don't even need to keep the tissue, because once we scan it, we're going to have all the information that we need. And I truly believe that this is just the first step, what we're doing with the tissue in the cassette that you've created. I think at some point we will just scan the entire tissue.
Tell me how you see that. What's your vision for this kind of workflow?
Well, I think that's super exciting, because if you think about the way that we function as pathologists right now, it's not very precise. We try to be as precise as possible, but we are using our eyes, which are not very they're not able to discriminate microscopic foci of tumor at margins. And so we choose the section that we think is going to be closest approach to margin, for instance. And that's a couple millimeters thick, and then we randomly take a slide out of that that's 4 microns thick. And that's where we make our decision as to whether that margin is positive. But imagine if we could instead use your technology, and the computer is able to evaluate it and say, this is the closest approach to margin, over a 4 or 5 or 6 centimeter area. This is the closest approach to margin. Then we would know for sure if that margin is positive or negative. So to me, that's the most exciting aspect of it, is that, eventually you'll put the tissue in 10 minutes, you'll have representative slides that the pathologist will look at and will determine what the tumor is, whether the margins are positive, whether there's LVI, whether the lymph nodes are positive, and you'll move on to the next case.
Amazing. That's so cool. So you are an early adopter, like you said, and like we said, both said, the changes always happen stepwise. What is your experience and approach to change management at your institution? Like, how do you deploy these things? Because you already did that for the glass-based digital pathology, and let's say this is going to be the next steps. What was your approach before? Would you change it? How do you navigate change management for new technologies in an organization?
Great question. Change management is always difficult because people don't like change. Most of us really don't like change. So
you have to learn so much, put so much effort, finally you're comfortable, and they tell you to change.
Yeah, I think it's also scary, and I think particularly, in a world where, many people feel like they don't have a lot of control over other things in their environment. Once you start making changes to their work environment, which is an area where they do feel they have a lot of control, that can be even scarier. So I think, one of the things that's really key is to find other early adopters within your organization, or people who are at least willing to consider it. And because once you get those people on board, if they're excited, if they see positive changes, they start talking to their colleagues. And then naturally, other people will approach you and say, hey, can we try it in my subspecialty area? And then once you get that momentum going, then it's unstoppable. Yeah, it's never a good idea to tell people they're going to have to do something. That doesn't go over well.
Is there a point where you have those that lag behind and don't want to change and you wait for this push when it's mandated in the change cycle?
Yeah, I mean, sometimes you do get to that point where you just have to tell people that we're moving to this, but it's better to try to make people, or not make people, it's better for people to naturally come to that decision themselves. It's also important to understand what the concerns and pain points are, because sometimes there are legitimate concerns that I may not recognize because I'm not a subspecialist in that area. And there are sometimes small tweaks that can be made in order to adapt to those concerns. So
definitely, it's a good point because and I'm a veterinary pathologist, so I do not, and not even a diagnostic one. I work for drug development, so my workflow is not a diagnostic workflow. It's a study-based, cohort-based workflow. So I don't work with cases, I work with groups of animals.
Yeah.
And to your point, when digital pathology took off, it took off first in the diagnostic and clinical space, and then the vendors would come to the pharma industry and would suggest these solutions for toxicologic pathologists, and very few understood the differences between workflows, even now.
Right.
And there are a handful of companies that decided to go and support these pathologists. Only few understood the workflow, so that's a super important point.
Yeah, we have, at UCLA, we've developed with in-house a software platform for tumor boards that we use with digital slides. And my service, the bone and soft tissue service, was one of the early adopters. And in the course of talking with some other services, I've realized that some of those services just can't adopt this technology as easily because of the way that their clinicians submit cases to tumor board, or the types of information that's needed from the pathologist to tumor board. So, that's another example of a system that to me worked so beautifully and made my workflow faster and more efficient. In another service would actually be worse.
And I always say about digital pathology that this is a multidisciplinary field, and then I take pathologists on one part of the field, but then what we are talking about, there are subspecialties, sub-workflows within pathology that will influence the excitement about the technology, the adoption, that people from outside of the pathology group, so other stakeholders would be IT, software development, I don't know who else is there, the image analysis, AI teams, right? Multidisciplinary teams of different backgrounds. And then we are this pathology group, but then within the group, it's not homogeneous. So figuring out the little tweaks, how to make it work, is the same thing showing a slide, but showing it to a toxicologic pathologist is totally different than showing it to a diagnostic pathologist. And then depending on specialty, you need also different hardware capabilities. So something I did not think about until I heard about it was, so first I was surprised, why does it, the first time I talked to a guest who was doing this transition, and he said, first this specialty went, and then that specialty, but this specialty, and that was genitourinary or kidney pathologist. And I'm like, why? Oh, because they need to do the polarization, and we don't have a tool for polarizing.
Yeah.
I'm like, of course. Yes. So I don't do it routinely, so I didn't think about it. And now there are scanners that do that as well.
Yeah.
But that's a little thing that, this one thing that is different that this specialty is doing from everybody else, that basically excludes them from being adopters of the technology. So a lot of analysis of different workflows.
Yeah, I also think that a lot of pathologists are scared that this is going to replace them. Digital pathology and AI will replace them. And I've been around pathology long enough to have seen multiple different innovations that were thought to they were going to replace pathologists, and we've not been replaced yet, right? So when I was first starting my training, it was immunohistochemistry, right? And then it was molecular, and now it's digital, and it's never going to replace us. It's going to make us much more efficient and accurate. So I think
it's going to help. It's going to change workflows. It's going to, and I'm obviously talking about the positive things, it's going to improve efficiency. But you're right, a lot of these questions are fear-based. That comes back to change management and fear of change. The same discussion when I was promoting the Muse panel on social media was from the histotechnologist side.
yes.
So yeah, they were basically like very protective of the specialty, asking, oh, well, is it gonna replace us? Will like you not need any education? And you know, there's this discussion parallel to the same discussion that we're having with AI. What's gonna happen? My take on that: those technologies, whichever that is, has a fantastic potential. But the application is a fraction of the potential that the technology has. And it's usually bumpy, so it still requires the subject matter expert to kind of guide it. As long as it makes your life easier and not more difficult, then I'm an enthusiast of that. But what I wanted to say, in addition to the histotechnicians, oh yeah, something that I learned from Rao in a previous interview that I did with him at CAP, and he was talking about it, that there is actually shortage of histotechnicians.
Yes,
So
there's a
how are
nationwide
you
shortage.
gonna, and because of the shortage, there are less places to educate them. So there is no like mitigation strategy to educate more people to become histotechnicians, and the job still needs to be done. So how are we going to do it? We have to solve it with technology. We have to solve it somehow, right? And Muse would be a candidate of a technology that could solve it. Then you're going to have new people who will have to learn this technology.
I think the job of histotechnologists will evolve, and so there'll be new activities that they do. So I think all of this, it's going to happen over a long period of time. None of this is going to happen rapidly. We'll have time to adapt to it and retrain
It's going
them.
to be changing in parallel with the whole like different way of doing pathology. Like I don't know how much their job changed with immunohistochemistry, with molecular, but definitely the workflows changed because you have to treat tissue differently. So they had to learn new things, and so did we have to learn new things. And one question that I want to ask you is about AI. Of course, we cannot finish this conversation without talking about AI. What is your current experience? Are you guys implementing anything? Are you guys working on anything? Like, what are your plans? How should AI support you? How is AI currently supporting you in your pathology work and your team?
So right now we don't have AI supporting us, but we are actively looking into it. I think that there are a lot of ways that it can and should help us. Again, to me, it's a physician extender, it's a pathologist extender, and a pathologist assistant. So, for instance, our hematopathologists spend a lot of time right now counting cells in peripheral smears and bone marrow biopsies, and to me, that's something that AI can do for them, and they can confirm. But I think that they spend a lot of time doing that, and to me, that's an area where they can be more efficient. We want them to be functioning at the top of their skill set.
Okay.
And I would argue that counting cells is not the top of their skill set.
No, counting. No.
And particularly now that they have to integrate molecular data and clinical data into their final diagnosis, and a lot of it is also the communications are more complicated with clinicians because the information that we're providing clinicians is more complicated and nuanced. I would rather them spending their energy in those areas than in counting cells. And same with other areas of pathology. I think that AI is going to be making routine diagnoses for us, and also it's going to be providing draft reports for us, which is going to save a lot of time. So, for a GI pathologist, a lot of the colon biopsies are preneoplastic lesions, tubular adenomas, hyperplastic polyps. Wouldn't it be wonderful if we had a scanner that could scan the slide and put up,
screen them
and create the report, and you still have to check it, but it's going to be a lot faster.
So you guys are looking into it?
We're looking into all of those things. And so right now there's some FDA approved AI products out there that we're looking at, and Again, that's part of Dr. Rao's job as Vice Chair for Clinical Innovation. Is to,
what's out there.
Right, and we also
see
have,
what would fit.
some of our clinical informatics folks are also on the market and, making sure that they know what's out there. So, yeah, I hope that we're going to be adopting some of those in the very near future.
Thank you so much.
Thank you.
So much
This was
for
really
joining
fun.
me.
Yeah.
And thank you so much also for, I love to showcase pathology female leaders.
Oh.
So, that's like a kind of side benefit of our conversation.
Yes,
I'm going to
for
highlight
sure.
you in the International Women's Day short video that I always have.
Wonderful. Thank you.
Thank
Thanks so
you.
much, Alex. It was really nice talking with you.